So how about getting rid of these antiarrhythmic drugs now? Now that you're ready with them, it should be pretty straightforward. Look, we're going to start with sodium channel blockers. So do remember we're going to have three classes of drugs, classes 1A, 1B, and 1C. And a class 1A drug, remember that diagram we just worked on together, is a class of drug that is known to block fast sodium channels. And that blockade of fast sodium channel occurs preferentially in the open or activated state. So now you see the third bullet point on your slide here tells you it would increase action potential duration and effective refractoriness. Look, we have just enough room to play with this a little bit together. And let's imagine that this is my normal action potential. You know we're going to talk fast response fiber because we're talking sodium channels, and sodium currents are only relevant to fast response fibers, which are primarily atrial and ventricular muscle, not nodal cells. So if this was the normal action potential, well, what would happen with a class 1A drug? Phase 0 is the upstroke of this action potential. I'm not planning on shutting down all ion channels. If I did, there would be no electrical activity and my patient would die. Rather, what I want is to just block enough of it to slow it down. Here we go. I'm slowing it down right now in front of you. You see, it took longer to actually get the upstroke of the action potential. Imagine, even if I kept everything else exactly the same. Well, now what did I do? I started my action potential right there, finished it towards the end of this red tracing, therefore increased action potential duration, which of course will have increased effective refractoriness. I really want you to recognize this for your step 1 or any step really. The fact is a class 1A drug would decrease the slope of phase 0. Well, that means on my exam, I could either give you the tracing and make you match the drug, or I could give you the drug or a clinical vignette where you would use such a drug and then tell you which of the following action potential tracing would be the relevant one with respect to the drug. So this is what a class 1A does. And between you and I, if you look at many review books or more complex pharmacology books, you know, beyond what we need to really understand for clinical use of drug, maybe for real pharmacologists, not people like us, well, in effect, they will tell you many other things these drugs do. For instance, even here with the Kaplan notes, we will tell you, by the way, like so many drugs, a class 1A has other pharmacology, such as blocking potassium channel, which would prolong repolarization. I'm not going to show you this on my diagram. If I did, it would confuse us with a class 3. And if it was that strong of an effect, then a class 1A would be called a class 3 and not a class 1A. So really, for us right now and for our step 1, make sure you know those first 3 statements. If you want to put icing on the cake, surely know that it also blocks potassium channel, and that helps. We'll work more on this with the class 3 drugs later. So who are class 1A drugs? Well, there are several of these drugs. One that comes to mind, which is a prototype for a class 1A, is the good old drug quinidine, which we still use so much. And quinidine, our first drug here in this chapter of the cardiac section, look what is first mentioned about it. It is also a muscarinic and an alpha receptor antagonist. So didn't I tell you ANS would show up everywhere? Here it is. Now, muscarinic receptor blockade, this is like which drug? Are you saying atropine? If you're saying atropine, perfect, because now you can tell me just at the level of the heart, what would you expect muscarinic receptor blockade would result in? Wouldn't it increase the heart rate? It sure would. And if it does, is that antiarrhythmic or is that proarrhythmic? Well, increasing the heart rate goes in opposition of what we were trying to do by blocking the sodium current. So this is a significant pharmacology of the drug quinidine, the fact that it will be able to precipitate tachycardias. As a matter of fact, now you're going to add to this antimuscarinic effect an alpha antagonist effect. Alpha blockade, as you know, would lower blood pressure. And lowering blood pressure would definitely result in potential for reflex tachycardia. So we have a drug there that has real duality. On one hand, it's an antiarrhythmic. It blocks voltage-dependent sodium channel. On the other hand, it's also a drug that can trigger tachycardias by being both muscarinic and alpha antagonist. Now, do we still use it? You bet we do. It has wide clinical uses in a number of arrhythmias. And one thing we like the drug for is particularly for atrial fibrillations. Now, clinically, atrial fibrillation, they're really not deadly per se, unlike the ventricular tachycardia, which could compromise your cardiac output right away. An atrial fibrillation really has two main worries attached to it. One, with a very rapid atrial beat, you can get some stasis of the blood in the atrial chambers. And we know that Virchow's triad told us that stasis, turbulence were one of three conditions with endothelial injury and hypercoagulability to actually cause pathological thrombi. So an atrial fibrillation could always result in the potential for thrombosis. These thrombi could then be ejected in systemic circulation, embolize, and go and cause infarction in other tissues, such as in the brain. Well, for that matter, then just for this, you'd want to treat the arrhythmia and certainly also use anticoagulant. The second portion of atrial fibrillation, if we think of it, is what if that fast atrial beat was propagated to the patient's ventricles? You know, running through the AV node and now causing the ventricles to go too fast. Then surely you would compromise that cardiac output and end up with a potential death of the patient because of atrial fibrillation causing ventricular tachycardia. So one of the big game we're going to do with atrial fibrillation management is generally to try and slow AV nodal conduction. So in a way we protect the ventricles of the patient. To slow AV nodal conduction, do you think muscarinic receptor blockade and the reflexes associated with hypotension because of alpha blockade will do that? Obviously not. Now we can bang our heads on the wall. We have a drug that actually speeds up AV nodal conduction because of its anti-muscarinic effect. Look therefore what we'll do. To slow AV nodal conduction, we will actually generally digitalize the patient. Now that sounds like you taking the patient and dipping them in a solution of digitalis. Not quite, but we're going to give them digoxin, basically. That's what digitalization means, giving the drug digoxin. Digoxin, as we'll see subsequently in the drugs for heart failure, is a drug that can also be pro-arrhythmic. So you know you will have to monitor with EKG the actual electrical function of that patient's heart while they're on quinidine and potentially digoxin. More to come on this in a second. So a drug that could actually be used in a number of arrhythmias, including atrial arrhythmias, but has a number of adverse effects. Here's a word for you. One word to tag to the drug quinidine is the word synchonism. Now, synchonism is one of these buzzword type of issue. I want you to know buzzwords. Buzzwords are important. They may not be the purpose of your board question, but they are used clinically, and what your boards will like of you is, can you tell them, and can you tell yourself for that matter, what does the buzzword refer to? What is synchonism? You see between parentheses a number of side effects. Look, it's pretty straightforward. You have a drug that has ANS pharmacology. It is antimuscarinic and alpha blocker. And the side effects of that ANS pharmacology is what we refer to as synchonism. For instance, let's try and work one. You see the GI? Tell me, if it's antimuscarinic, atropine-like, what should be the GI effect? Constipation, wouldn't it be? Now at the same time, it's alpha blocker. So obviously it means sphincter tone is relaxed. So what is the patient having? Diarrhea or constipation? Well, in a way, the patient would get either. And you know, this is one of many cases where when you look at the effect of a drug, you might see literally in a textbook or in your PDR, side effect, diarrhea / constipation. And sometimes we wonder, how can a drug do both? Well, now you see, all it would have to be is both antimuscarinic and alpha blockade. To me, that means GI distress. That should do it. Look, another big spot. Of course, my patient will complain about ocular dysfunction. Think of it. You have a drug with antimuscarinic effect that would dilate pupil, causing mydriasis, causing blurred vision, cycloplegia. Yet, as an alpha blocker, it would like to do meiosis. So what is it going to do to the pupil? Who knows? All you know is that it's going to be messed up. And people will have problem accommodating, will have also problem adjusting to different light environment, maybe having some night blindness or being totally blind by too much sun also. So we just leave it as ocular dysfunction. Having an antimuscarinic effect when you cross the blood-brain barrier can result in significant CNS excitation. It can result also in issues with hearing, with tinnitus. All this is what we call synchonism. So why did we call it synchonism? Now that's for you and certainly not for your exam to ask you about. You notice that quinidine sounds like quinine. And if it sounds like quinine, it's because it is structurally related to quinine, structurally related to all the antimalarials out there. Well, antimalarials, they were actually isolated from the bark of a tree. And that tree that grows in South America actually is called a cinchona tree. And cinchona, if that's the name of the tree, you can understand now what people have given as a name to side effects of all the quinine or bark alkaloids that came from that wonderful tree of ours there. Quinidine, therefore, is said to cause synchonism. Never use that word except for anything that sounds like quinine or quinidine. As far as one big potential, which is that of tachycardia, well, when you speed up AV nodal conduction, it means you're going to start depolarizing your ventricles sooner. If you start them sooner, the QRS will start sooner on your EKG. You will also maintain the cells depolarized longer. So now your T wave will occur later. That means you will see a prolongation of the QRS and therefore an increase in the QT interval. This is what we call torsade type of rhythm, you know, from the French torsade, which means a twist. And let me show you in a way on another slide what this really would mean. Here we go. You recognize P wave, QRS, and T. Now let me exaggerate a little bit and spread my QRS. There's my P wave, and now there's my QRS. Is that okay? Now, as you're looking at this, ultimately what we mean by torsade is that your EKG is literally going to only look like QRS complexes. So it's going to end up looking something literally like this. And as you're looking at that type of pattern, this is what we refer to as torsade, and in half of the cases, it'll bring that patient to ventricular fibrillation and potential death. This is classic of anti-muscarinic drugs. So as such, now know that quinidine, an actual antiarrhythmic medication, can cause this life-threatening side effect, that of torsade, simply because it's also an anti-muscarinic drug. For a drug like this, you'd better know also some drug interactions. No doubt, anything that would worsen the toxicity would be quite relevant because of the potential for life-threatening arrhythmias. Well, one electrolyte always comes to mind, potassium. Hyperkalemia will enhance the effects, being that hyperkalemia depolarizes the cells further, so making sure that the ventricular arrhythmia is more likely. The other drug interaction is more board relevant than it is clinically significant. It's the issue of digoxin. Do you recall that in the general principle, quinidine and also the drug verapamil could displace digoxin from tissue binding site? Well, if that was to happen, then digoxin would be enhanced in its free fraction and would now be able to be more cardiotoxic. The relevance of this interaction to your exam, we just mentioned that in atrial arrhythmias, we needed to digitalize the patient in order to use the drug quinidine. So quinidine and digoxin go hand in hand, basically. So as a side effect, as a drug interaction, you surely would want to monitor EKG and also the levels of the drug so that the patient would not suffer toxicity from either. Quinidine is your prototype. There's certainly other class 1A drug, and the one to know is procainamide. The reason to know procainamide is not so much to repeat everything we said for quinidine. It is actually anti-muscarinic, although it is a little bit less anti-muscarinic. The main idea is you must know well that procainamide is metabolized by conjugation through the process of acetylation. N-acetylation is genotypically determined. A point in the general principle was to remind us of slow and fast metabolizers. And when I'm thinking of slow and fast metabolizers, a slow metabolizer would build up the level of the drug procainamide. Procainamide is a good hapten. And as a good hapten, as soon as it's protein bound, it could actually trigger hypersensitivity reactions. Procainamide is very broadly distributed in all tissues of your body. It has a high volume of distribution. It loves to bind to tissue protein. This is the mechanism by which it'll trigger systemic immune responses that we obviously are going to call SLE-like. What were the other two drugs that were associated with SLE-like syndrome and slow acetylators? Are you thinking hydralazine, the antihypertensive, and isoniazid, the anti-tubercular drug? Because these are really classically three drugs often tested on the exam for this mechanism of SLE-like syndrome. Now, don't forget that as SLE goes, this is not a disease. This is drug-induced. So epidemiology-wise, forget about the 10-to-1 ratio female to male here. And whether you're male or female, you could get SLE. Age is irrelevant too. Really what is more relevant is to be a slow acetylator to build the drug up. Also another key point, when you look at SLE, multisystemic, well, the primary worry with immune dyscrasias associated with drug is the actual blood toxicity. The hematotoxicity of drugs that are immune in nature for their injury is unfortunately unpredictable. So it will require you to do regular CBCs, that is complete blood cell count, to monitor particularly white blood cells and platelets. With white blood cells, don't forget that a sudden drop or destruction of these cells could result in an overwhelming infection, as well as bleeding potential from the thrombocytopenia. It does mean that in the SLE-like syndrome, you worry about the blood, you may worry about the rashes. Very seldom you'd worry about all these glomerulonephritidis that we love so much to associate as a severe symptom with SLE. Other point of SLE-like syndrome, we must remember that on the testing in the laboratory, we will see positive ANAs. Just like SLE and a number of other autoimmune disease, what we will not see are positive double-stranded DNA and positive anti-SM. The classic antibody to measure is the positive antihistone, which is very specific to the drug-induced form of SLE. Of course, finally, you remove the drug and the SLE-like syndrome should be over. Otherwise, last point of procainamide, let's not forget it's a class 1A. Just like quinidine, it does block muscarinic receptor, therefore torsade. There's still a potential for this drug. Really dwell on the SLE-like syndrome. That's where your money is for the drug procainamide. Not in your syllabus, but if any of you still remember a drug that is still in use, that's called disopyramide. Well, you know, be my guest, add it. It never hurts to know another drug that is often used for that matter. And disopyramide is another class 1A, just like quinidine and procainamide would be. Let's look at a class 1B drug. On our diagram of the previous chapter, class 1B drugs were unique in that in their blockade of channel, they were more specific for the inactivated sodium channel. Now, you might wonder, what am I going to do if I'm blocking a channel that's already closed? Well, let me go back to that diagram 1 second. Imagine I am blocking that inactivated sodium channel. Certainly I'm not changing any flux of sodium into the cell because the channel is indeed closed. However, as I'm holding that channel in this conformation, what I am preventing is its return back to resting. So effectively what I'm doing is keeping those cells in the hypoxic tissue refractory. So one way of understanding the class 1B is literally by blockade of the inactivated sodium channel to prevent the cells from going back to resting and therefore from firing new action potentials. The relevance of blocking these inactivated channels is that we've explained already hypoxic or ischemic tissue has a number of these targets for the class 1B to bind to. In effect, these inactivated channels are slowing the conduction of electrical activity in those ischemic tissue. This is where the arrhythmia actually arises. Healthy tissue that's firing fast and perfectly fine versus the hypoxic tissue next door that wants to go too slow and causes really disparity in the way the waves of action potentials are propagated in the muscle. This first mechanism of action of a class 1B, well, this is often board tested, but you cannot imagine it on the tracing of an action potential. So we need to be able to relate it to an action potential, and I think that's the primary reason why the board digs out another pharmacology of a class 1B. A class 1B is capable of decreasing action potential duration. The way it does this is by blocking this famous slow sodium window current. That's the current we talked about in our diagram in the fundamental concepts. You know, this sodium current that occurs during the plateau phase while calcium comes in and potassium leaves, and in a way helps maintaining the integrity of that plateau and the length of this plateau. Thanks to this, here's what we're going to be able to do for our exam. We're going to be able to take a fast response fiber action potential, And because of the blockade of the actual sodium window current, I'm going to be able to say I'm doing nothing with a class 1b to phase 0, but once I get to the plateau, it's going to shrink. And as it shrinks, this is the effect that is notable of a class 1b on an action potential for your board exam. So notice the difference between class 1b effect on action potentials and class 1a. Now let's think about this 1 second. We have shrunk the action potential. It has gone down. In any healthy cell, that would be understood as being pro-arrhythmic. But here, I have slow conduction. In a way, I'm allowing the cell to recover faster. Recovering faster either can help it to go back in par with the healthy tissue for electrical speed, or, because of decreasing the APD, allow more time during diastole for filling, and thanks to this, improve the cardiac output of that ischemic heart that is in the process of failing on the patient who has a myocardial infarction. There is really one class 1b drug to know of. It is the drug lidocaine, the same drug we'll use as a local anesthetic. It is primarily used post-MI in open heart surgery because we actually have a tissue that is depolarized. Remember how we remove all the blood from the patient's body and circulate it in a separate machine while we work on that patient's heart. It is also a potential. I'm not going to highlight this one too much. The other one I would like you to know besides post-MI really is during digoxin toxicity, since digoxin by blocking sodium pump is also going to depolarize that heart muscle. So really know well post-MI and digoxin toxicity. Lidocaine can cause some electrical problems in CNS and of course in the heart, like all antiarrhythmic that works on action potential. The thing that is noticeable here is to call it the least cardiotoxic of conventional antiarrhythmics. It's always something that made me laugh because when you think of it, lidocaine, when it's used as a local anesthetic, one of the worries we have in local anesthesia is the potential toxicity of such medication, as we'll see in the CNS later on. So to call it least cardiotoxic, what do you think it must mean about the other drugs? Obviously, something to think of. That's why sometimes electrical cardioversion would be a better choice initially prior to chemical cardioversion. Nonetheless, lidocaine is used, and when it's used, we saw already in the general principle that it's only used IV. It's only used IV because of first-pass metabolism digesting that drug. So what if I wanted to send that patient home with a class 1B? Obviously, I'm not going to send them home with lidocaine. This is possibly the only reason why you would stuff your hippocampus with 2 more drugs, mexiletine and tocainide. Mexiletine and tocainide are lidocaine-type drugs, but they're available in oral formulations. What should I do about a class 1C drug on my exam? Well, the same thing as I would do in real life. This is a second choice drug. This is, to me, what I would call a passport to heaven type of drug. You know, nothing else is working, so before we let the patient go, why not try and give that drug? And potentially, the patient will respond to it. A class 1C blocks any sodium channel shape. Because of this, in effect, you don't have to worry about any change in the shape of the APD. In my mind, it's as if either you have an APD or you literally don't. And that is really one of the big problems of it. A drug like flecainide, which is the only one we'll see as a class 1C since it's poorly tested, is limited in its use because it is so pro-arrhythmogenic. It has led to sudden cardiac death in multiple studies, showing that sometimes actually patients might do better on placebo than they do on flecainide. Why do we still have it for practice? Well, because it's a last-stage drug, and some people will be saved by a drug such as flecainide. So don't think of it as a first choice in ventricular arrhythmia, but rather as another choice in case more conventional drugs, such as amiodarone in particular, or such as drugs like quinidine, procainamide, or lidocaine would not be functional.